assistant professor in orthopedics department in Changalpet Medical College. So he'll be joining us and we'll be clearing all our doubts. So he'll be joining us shortly.
Hello.
Hi, sir. How are you?
Yeah, I'm good. How are you?
Yeah, I'm fine, sir. So we are having a lot of doubt regarding this orthopedic emergencies and all. So I hope you'll clear all of our doubts.
I hope I can do that.
May I ask you the first question, sir?
Sure. Please go on.
So as the heading itself says, how to handle the orthopedic emergency. So what is orthopedic emergency and how often is the emergency rooms filled with these kind of emergencies when compared to other departments?
Yeah. See, actually, like all of us, like not all of us, I mean, like most of us have the misconception that no matter, like, when you have a fracture, that's an orthopedic emergency, but that's not really true. Because, like, not all the fractures are actually emergencies. And in fact, like, fracture as such is not an emergency. Okay. So, like, to be tell you, like, what are the real orthopedic emergencies? I would say, like, I mean, basically, it's only three which need like immediate attention and treatment. So they are, one is dislocations, any joint dislocation as such, and then second would be septic arthritis, and third is compartment syndrome. So these three are the real orthopedic emergencies. And if you have to, like, add something more to that, like, maybe a semi-emergency, I would say a compound fracture or an open fracture. So these are actually the real orthopedic emergencies. So, and whatever, like, the picture that is depicted here, most of it is actually not an emergency. And even if you delay the treatment by a few hours, see, for example, okay, you get a patient with some fracture. So it doesn't mean that you need to, like, treat the patient can be treated conservatively with the slab, which probably, like, anyone in the ER can do it. And the orthopedician can attend to them the next day. For example, you get a patient at probably, like, 10 or 11 in the night or maybe midnight. Anyone in the ER can manage this, and the orthopedician can, like, come in the next morning and they can take care of it. So that's not a real emergency as such. Whereas dislocations, yeah, it needs immediate attention and treatment. Septic arthritis, definitely, and so is compartment syndrome. And compound fractures, yeah, because of, like, various reasons and with emerging treatment for compound fractures. So yeah, compound fractures are like a semi-emergency, I would say. Hello. Hello. Hello.
So 1 minute, sir. I don't know what happened to the host. I'll just check.
Yeah, sure, no problem.
Hi, sir. I was there was some network issues and all. Sorry,
Sure.
sir.
Yeah, no problem. Please go ahead.
Okay. So next question is, which is the most common orthopedic emergency that I've seen?
See, probably I would say it's dislocation. Dislocation is the commonest one because you don't, like, probably dislocation you would see at least 2 or 3 cases in a day. And whereas, like, compartment syndrome and septic arthritis is probably, like, twice or thrice a month maximum.
Okay.
Yeah.
So, what is the difference between dislocation and fracture?
Dislocation and fracture. Yeah. See, fracture is nothing but a breach in the bone continuity, right? That's so when the bone is broken, that is fracture. Whereas dislocation, see, fracture is a breach in the continuity of the bone. That is what we call it as a fracture. Whereas dislocation is when the joint slips out, like completely when there is no connection between the, or when there is absolutely no this thing disloc. I mean, what do you say? There's no connection between both the articular surfaces of a joint. You call it as dislocation. Whereas subluxation is something like, subluxation and dislocation. Subluxation is when the joint is partially dislocated. That is, for example, if you take in case of a shoulder joint, for example, so shoulder joint is actually the articulation between the glenoid of the scapula and the head of the humerus. So when the head of the humerus slips out of the glenoid cavity, you call it as dislocation of the shoulder. So when there is absolutely no contact between the head of the humerus and the glenoid cavity, you call it as a dislocation. Whereas when the head of the humerus is partially displaced, wherein there is some contact between the glenoid as well and the humeral head, you call it as a subluxation. Whereas a fracture is okay, maybe in these pictures you can see there are a lot of fractures, a lot of femur fractures are there. So when a bone is broken, you call it as a fracture.
Okay, sir. So, when talking about dislocation, which is the most common site of dislocation and how can we handle it?
Yeah, see, the most commonest is again shoulder. So shoulder probably would account for 80 to 85% of the dislocations that you see on a day-to-day practice. See, here you have the picture. So dislocation is when the articular surfaces, that is when the joint is when the joint or the articular surfaces are displaced, you call it as dislocation. The picture on your left side. Whereas a fracture, see here you see a shoulder dislocation, and the other one is you see neck of humerus fracture. The picture on your right. And yeah, coming back to your question, yeah, shoulder dislocation is the commonest. Probably accounts for about 80 to 85% of all the dislocations that you see on a day-to-day practice. Followed by hip, then elbow, ankle, and yeah, finger and toe dislocations are also pretty common.
So, to how to handle it then?
See, okay, how to handle it? Okay, so how do you clinically make out that a patient has dislocation? Okay, see, let's again, let's take the example of shoulder again, because that's what you're going to commonly encounter in your ER or even in your OPDs. So again, so it all depends on, first and foremost thing, the striking feature is the attitude of the patient. So the attitude is the position of the limb. That's what we call in orthopedics. Attitude is the position of the limb. So here in shoulder dislocation, again, coming to shoulder dislocation, there are there is anterior, posterior, and inferior. So inferior is not very common. Again, among these, anterior is about 90 to 95% of dislocations in the shoulder are anterior dislocations. So what would be the attitude of the patient with the anterior shoulder dislocation? So the patient typically comes to you with almost they'll be holding their arm, they'll be holding their forearm because they won't be able to adduct it. That is, they won't be able to bring the arm to the side of the chest. Okay, so this will be the position of the patient. They'll be exactly, this is what. So I guess this would be easy for you too. So the patient will be holding their arm and they walk and come to the OPD. So this is one thing. And second thing, there are some, once you ask the patient to remove their shirt, then you will be seeing a very prominent acromion. The acromion process over here, it will be very prominent because the joint is dislocated. So the acromion pops out it is very, it is visualized, and you also see there's flattening of the shoulder. What? See, no matter how thin the person is, you'll be able to see the deltoid contour. So the deltoid contour is usually the shoulder is rounded normally, whereas in a patient with dislocation of shoulder, so the sides of the shoulder will be completely flattened. So that is one thing. Then there's a test called as Dugas test, which is commonly done. which is nothing but Duga's test is asking the patient to touch the opposite shoulder. So when you ask the patient to do this, touch the opposite shoulder, he won't be able to do that. Okay, so this is one thing. Yeah, and then, okay, now clinically you made out that the patient probably has a dislocation. Yeah, then the next thing is, then you should see whether patient has any complications associated, because sometimes, it's not very common, but very rarely, patients can have some nerve injuries. So common ones are axillary nerve injury and musculocutaneous nerve injury. So axillary nerve injury, again, like it is difficult to test on a patient with dislocation. So you can just check for their sensation. So axillary nerve, to check the to check whether the axillary nerve is intact or not, then you have to check for the patient's sensation at the deltoid level or this region. So when the sensation is present, then you are very sure that the axillary nerve is intact. Whereas when patient complains of numbness or he's not able to feel your touch, or like when you try to pinch him, he's not able to make it out, then probably he has an axillary nerve injury. And again, to check for muscular cutaneous nerve, you again have to check for the sensation in the anterolateral forum, over like somewhere around here, near your brachioradialis. So that is where you have to check for the sensation, because making out for the power in a patient with dislocation is not easy. So why this is important? Again, like when you encounter a patient with trauma, be it fracture or dislocation, always look for, do the relevant neurological examinations, as well as look for the distal pulses and capillary refilling. So here again, in upper limb, you have to look for brachial pulse, radial ulnar pulse, and also look for the capillary refill time. Capillary refill time, again, like you just, whether be it the finger or toes, just try to pinch just under the dorsum, okay, just here, and once you leave it, normal capillary refill time is about less than 3 seconds. So once you press, you see the finger blanches. So once you release, again it has to refill. So this is what we call it as capillary refill time. So this indicates any microvascular, when there is a vascular injury. Okay, when there's a vascular injury, this timing gets delayed. It takes about 7-8 seconds to fill up. So which means that probably they have some vascular injury. But that is not really relevant in a dislocation, a case of dislocation. All these are relevant in cases of a major fracture, especially femur bone fracture, or when there's a compound run over injury, or when there's a gross compound fracture. In such cases, it is always but you make it a habit whenever you have a case of trauma, you always do all these so that you don't miss out anything untoward. And yeah, so coming back to neurological examination, why is it important? Because sometimes you have to document it, pre-reduction and post-reduction. Because sometimes when we try to reduce, as a part of the treatment, when we try to reduce the dislocated joint, we might, iatrogenically, we might cause some nerve injuries as well. So that is why it is very important to document it, prior to reduction, whether the patient had any nerve injury or vascular injury, and post reduction, was there any injury or not. So because even medical legally, this is very, very important. And
Thank you, sir. And even
yeah, sorry, see again, so this is clinically you have evaluated the patient. Then next, coming on to radiological examinations, again you have to take an x-ray. See, but again, looking at an x-ray, it is you won't know whether the dislocation is anterior or posterior. So it is more of a clinical examination which is going to reveal, because first and foremost thing, in anterior dislocation, the patient's attitude is, as I already told you, it's going to be an abduction. Patient won't be able to bring their arm towards the shoulder, okay, to the sides of the shoulder. Whereas again, on the contrary, in a posterior dislocation, it is the patient's attitude is sling position, wherein they'll be holding their arm this way, they won't be able to adduct it. So, but just looking at this, you can't really say whether, just looking at the head of the humerus, you won't be able to say whether it is anterior dislocation or posterior. Here, it looks like, it's in slight abduction. Yeah, it's in slight abduction. So probably this is an anterior dislocation.
okay, sir. Even hip and shoulder dislocations are very common. Even a close friend of mine was also having that kind of dislocation, hip dislocation. And so, what do you think about it? Can you describe it and how to handle those kind of dislocations?
Okay, right. See, again, coming to the hip dislocations, yeah, it is not that common as shoulder dislocation. That happens, but hip dislocations usually happen in it's usually like, high velocity injuries cause hip dislocation, whereas shoulder dislocations are even like, just a fall on an outstretched hand usually causes a shoulder dislocation. Or when you, like, when patient, when a person tries to jump from, for example, first floor, he just falls off the first floor, whereas he tries to catch hold of something, then it is, I mean, like, he's going to encounter a dislocation. Whereas hip dislocations usually happens after high velocity injuries. Yeah. Example like dashboard injury in case of, like, when you travel in a car due to sudden brake, when there's a dashboard injury, yeah, it causes hip dislocation. Again, in hip, posterior dislocations are very, very common. Probably, I would say, again, like, 90 to 95% dislocations or even more is posterior dislocation. And maybe like, 2 to 5% must be anterior dislocation in hip joints. And again, like hip, again, coming to posterior dislocation, it is again, and if you look at the patient, when the patient comes to you, the ER, when he's got to the ER in the stretcher, his attitude will be like the hip will be flexed and adducted and rotated inwards. So there's flexion, adduction, and internal rotation is the attitude for a posterior dislocation. Whereas for anterior, it is usually flexion and slight abduction, and it's more of external rotation. So anterior sometimes can be confused with neck of femur fractures or even like, intertrochanteric fractures. And next you have to, like, both, sorry, I missed out one point, like in both shoulder and hip, or like, be it any dislocation, palpation also reveals. When, for example, in shoulder dislocation, when you try to palpate, normally you won't be able to easily palpate your humeral head. Whereas in shoulder anterior dislocations, it will just be lying just under your pectoralis, and it is like, very easy to palpate. Again, when it comes to posterior hip dislocation, when you try to palpate the patient's gluteal region, it will just be popping out there. So again, palpation reveals the position of the dislocated part. And like in shoulder dislocation, again here the neurovascular injury also can happen. Again here, sciatic nerve is at risk to get injured. And again, like, then you go proceed with radiographs. Sometimes nowadays CTs are becoming more common because it's not just dislocation. Sometimes there are, like, there are cases where there is, like, fracture dislocations which happen. So for example, in hip, acetabulum can fracture along with the dislocation, or sometimes femoral neck can fracture, femoral head can be shattered. Like 3-4 days back, we had a case wherein, like, in the hip, along with hip dislocation, the femoral head was in, like, 3-4 parts actually. So in such cases, a close reduction is not really possible, or even if you do, it's not like, concentrically it is not reduced, because parts of certain, I mean, parts of the fractured head will be lying somewhere, so you need to open, you need to reduce, fix it. So that's how it is. And again, shoulder also, like, usually commonly the greater tuberosity in the shoulder can fracture along with the dislocation. And posterior dislocations in the shoulder are very common in epileptics. In epileptic patients, posterior dislocation is very common. And again, when you get a patient with electrocution, then immediately check for the shoulders, because a lot of people with electrocution, they tend to have shoulder dislocation and especially posterior dislocation. So just remember these two things.
Okay, sir. And another type of dislocation is the elbow and knee dislocation.
Okay.
So, how can we handle that kind of dislocations?
See, any dislocation, basically there are, like, various techniques to reduce it. Elbow, again, yeah, elbow, posterior or posterolateral dislocations are more common. See, I'm not very sure, like, see, dislocation, when it comes to dislocation or a fracture, when you describe a fracture or when you describe a dislocation, see here, for example, okay, forget the elbow. Let's talk about the knee dislocation. Here, with this view, I can say this is a posterior dislocation of the knee joint. So how do I say it's posterior and not anterior? Because most of the times we tend to think that, because when you look at this patient, his knee will be prominent anteriorly. So we tend to think that, okay, we know there's an anterior dislocation because a lot of them tend to make that mistake. But see, when you talk about a dislocation or when you talk about a fracture displacement, it is always because you consider the proximal part of the bone or the proximal part of the joint to be fixed. Okay. And so it is always the position of the distal fragment in case of a fracture, or the distal bone or the distal part of the joint in case of dislocations. So depending on where they lie, then accordingly you, see, for example, here the knee joint, the femur is lying anteriorly and the tibia is lying posteriorly, right? So here the femur is fixed to the body, whereas the tibia is dislocated. So the tibia is lying posterior to the femur. So you call this as a posterior dislocation. Whereas, when you look at this patient, his knee will be popping out anteriorly, actually. So we tend to think that this is an anterior dislocation, but that's not right. Okay, so that is one thing always you remember when talk about dislocation or fracture, it is the position of the distal fragment or the distal part of the limb, wherever it is lying, that is the, based on the position of the distal fragment, you talk about the displacement. Okay, so yeah, see, be it elbow, knee, or even finger. See, elbow and knee is pretty rare, I would say. You don't very frequently see knee dislocations, whereas shoulder, hip, elbow, yeah, at times. And actually, after shoulder, I would say like finger and toe dislocations are more common. And then comes elbow, and then you have ankle. Sometimes, isolated ankle dislocations are happens, but very rare. Usually, it is associated with some fracture, either talus fracture or it happens with the distal tibia fracture dislocation. So yeah, and knee dislocations are pretty rare. Knee, again, spine dislocations. Yeah, even spine can dislocate. Facet joints can dislocate, or spine as such can subluxate. So yeah, again, see, again, the treatment is the same, protocol is the same, and you have various reduction techniques. For each joint, you have various reduction techniques. Do you want me to talk about it? Because see, for each one, if you're going to go in detail, I guess we won't have time to talk about other things. Maybe for the shoulder, okay. See, the concept is simple. Without disturbing, see, irrespective of like which dislocation it is, just trying to maintain the patient's attitude. Usually, it is based on one thing: traction, counter traction. Okay, so one person gives traction, inline traction. So inline traction is okay. For example, in case of a shoulder dislocation, anterior dislocation shoulder, this is how the patient is going to be. Okay, so one person is going to stand here and he is going to give traction, whereas the other person in the axilla, some people try to hold it, whereas the other people normally what we do is we put a towel along the across the axilla, and so one person lies, one person stands towards the left of my shoulder, and then he applies a counter traction. So when you give this traction and counter traction, what happens is whatever it is, wherever it is locked, it sort of pops out. Then you have the option to maneuver. So normally in shoulder dislocation, anterior dislocation, you just remember there's a mnemonic, to know what is the sequence of reduction. It is called as Team's maneuver, TEAM, team. Okay. So it is nothing but traction. So you give traction. So once you'll be hearing a pop-up sound, because see, it is dislocated and it is lying somewhere here, it will be locked somewhere. So when there is traction and counter traction, it sort of comes out. So then you externally rotate the limb. Okay, E stands for external rotation. So that is when it completely comes out of the cavity, or there'll be some soft tissue. It will be some soft tissue will be impinging the muscles. So it completely comes out, and then maintaining the external rotation, you adduct the limb, and then M is medial rotation. It's actually medial or internal rotation, and you put the arm on the opposite shoulder, and you just trap it in that position. Okay, so it is called as Team's maneuver, TEAM, stands for traction, E stands for external rotation, A stands for adduction, and M stands for medial rotation or internal rotation. See, and yeah, so there are like various techniques. Again, in shoulder, there are about like some 20 to 30 techniques which have been described to reduce the shoulder. So this is the commonest one which is being done. And so no matter like which joint gets dislocated, most important thing is post reduction. You're supposed to give some time for the soft tissues to heal, because unlike fracture, here the soft tissues are damaged and not actually the bone in case of a dislocation. Okay, so because the soft tissues have given away, see, any joint, it gets its stability only because of the soft tissues. Okay, so when there is a soft tissue tear, see, for example, shoulder, the capsule, the labrum, the muscles, all this rip apart when there is a dislocation. So, for example, okay, here in this picture, there is a hip dislocation. So, right from your posterior capsule to all your gluteus, everything will be torn, and for this bone to, for it to give away. So, only then this femoral head can dislocate and it will migrate upwards. Okay, so when you reduce, again there won't be any stability there, because your just your um, acetabulum fossa is not good enough to hold the femoral head in place. So it is because of the labrum and also the capsule and other soft tissues. All these together gives the stability for the joint. So here any dislocation is actually more, the trauma is more to the soft tissues than to the bone actually, except until unless when there is a fracture. Okay, so after reducing any dislocation, you need to immobilize that joint, okay, for at least a period of about 4 to 6 weeks to prevent any future dislocations, where which we commonly call it as recurrent dislocation.
So what do you think about the small joints in the hands and all, the dislocation of those joints?
Yeah, see, again, dislocation of those joints, like, in hand, commonly you encounter metacarpophalangeal and interphalangeal dislocations. They are pretty common. Okay, any metacarpophalangeal or this thing, the interphalangeal joint dislocations are pretty common, whereas carpometacarpal, pretty rare. Yeah, see here you can see a proximal interphalangeal joint dislocation. Okay, so yeah, again, see here what you do is you try to give a local block. Okay, you can give a digital block. You don't need an anesthetist to do that. I mean, like most of the times we do it ourselves. So once you give a block, you just try to reduce it, and you strap. I mean, like you call something in hand and foot. You call something that what we normally do is called as a buddy stapling or buddy strapping. That is nothing but you just keep a piece of gauze in between the fingers or toes which you want to immobilize, and just put two plasters, like at the level of the proximal phalanx and the distal phalanx, and the gauze is kept in between to prevent any friction dermatitis. That is called as, I mean, like you will be reading about it like later. It's called as buddy stapling or buddy strapping. So this is what is commonly followed for the hand as well as the foot. And sometimes, yeah, sometimes all these dislocations, no matter which joint it is, sometimes it is irreducible due to various reasons. So when a joint, when you try to reduce it, and when you're not able to do it, there are various reasons. Because one is probably when you don't give general, and ideally any joint to be I mean, to be reduced is to be done under general anesthesia, because first and foremost thing, the patient should be pain free. Because normally when you try to reduce a shoulder dislocation, but 90% of the times we don't do it, we just do it without any anesthesia. Because when the patient has pain, he tries to contract the muscles. So actually many times there is possibility of us causing fractures, because it is a struggle. It's a battle between the patient and you. Whoever is more strong, you try, if you are more strong, okay, you apply more force and you try to reduce it. And when the patient is more strong, he tries to resist. Ultimately there's going to be some fracture. So yeah, so when there's inadequate anesthesia, you won't be able to reduce it. And sometimes when there is a fracture dislocation, it is sometimes you won't be able to reduce it completely. And then when there is soft tissue interposition, you won't be able to reduce it by closed means. Yeah, probably these are the common things which prevents closed reduction. So in such cases, then you have to go in for an open reduction. Open reduction is give anesthesia, you open like a surgery, you need to open, then you need to reduce it, and then if there is any fracture, you fix all those fractures, whichever requires fixation, you fix them, and then you repair all the capsule and all the soft tissues, whichever the soft tissues which are torn are repaired, and then you do a closure.
Okay, sir. So as you mentioned in the starting, you told us about the intercompartment syndrome.
Compartment syndrome. Okay.
Yeah, intercompartment syndrome. So what is it,
Sorry.
and what are the causes of it, and how can
Compartment.
we handle it?
Okay. See, it's actually not intercompartment, it is compartment syndrome. Okay. See, compartment syndrome.
I think he have lost his connection. He'll be joining us shortly.
Hello. Hello.
Yeah, sir, we can hear you.
Sorry, I switched off
Yeah.
my computer by mistake here. Sorry. Okay, so yeah, so it's a compartment syndrome. So compartment syndrome is nothing but, yeah, see here you get to see. See, we all know, in forearm, in arm, the limbs as such, the muscles are actually encapsulated in various compartments. Okay, let's talk about forearm. Forearm, normally there is a flexor compartment and an extensor compartment. Again, flexor, you again divide it into superficial flexor and deep flexor. Okay, so this is nothing but compartments are nothing but they are, I would say, when the fascia, you all know, the deep fascia. So the fascia encapsulates certain muscles, nerves, and vessels, and bone, of course, within it. So that, I mean, this, all this together, you call it as a compartment. So again, likewise, if you're going to talk about leg, which is again commonly where you see compartment syndrome. Again, leg, you have an anterior compartment, a lateral compartment, and posterior. Again, in posterior, you have a superficial and deep compartment. So there are 4 compartments in case of a leg. So a compartment syndrome is nothing but when the pressure inside, see, normally there is some minimal pressure inside each compartment. So when the pressure inside a compartment, be it 1 or 2, in particular part of the limb, when the pressure exceeds the normal limit, which is the permissible limit, it causes various problems. So that is what is basically compartment syndrome, is increased intracompartmental pressure. So that is compartment syndrome. So what is it and what does it do, or what are the causes for it? Okay, see, coming to the causes, common things, I mean, commonly it is following a fracture, commonly following a fracture. But many a times, even without fracture, for example, a patient would have, especially in our setup in South India, which you commonly see is, many a times you get to see people, especially children, who would have sustained a normal, just a bony contusion, or should have been just a contusion, but they immediately take the child, or to any person, they take them to bone setters. What they do is they vigorously massage and they apply a tight bandage. Okay, so what happens is, this tight bandage, this sort of compresses. See, normally, I don't know how many of you would have attended orthopedics. Okay, so if you had attended, normally when you have a fracture, okay, you plan to immobilize, or you plan to treat the patient conservatively, you apply a POP. Okay, nowadays it's more of a fiberglass is taking over POP. So you put a slab. A slab is nothing but when you apply POP or a fiberglass on one side, we call it as a slab. Whereas a cast is nothing but the same material is applied circumferentially all around 360 degrees. That is called as a cast. So normally in case of an acute setting, we usually prefer doing, I mean, we prefer applying a slab. For main reason is because when there is an injury, whether there's a fracture or not, when there's an injury, there is going to be some swelling. So what you do is, why do you need to first and foremostly, why do you need to apply a POP? So the POP is the use of POP. It is not going to see whether you apply the POP or not. The factor is going to unite. But the main purpose of applying the POP is you try to maintain the bones in the near normal position. And then second thing is to alleviate the pain, the swelling, and the subsequent inflammatory process. So that is the main motto of applying a POP. So why we apply a back slab, POP slab is because when you apply a slab, okay, you're only covering about probably 160 to 180 degrees of the limb. Even when there is swelling, okay, see, after an injury, the swelling is going to increase for a few days, and only then later it is going to subside. So when there is swelling, when when you apply POP on one side, the other side is only covered just with cotton and your bandage roll. So they both have the capacity to expand even when there is a swelling. Whereas a POP or fiberglass, that doesn't forgive and that doesn't expand, because once that sets, it is going to be rigid. So, for example, okay, when there is a swelling, okay, you have a patient with a distal radius fracture. You applied a cast, okay, or sorry, for example, you applied a slab. If there is going to be swelling, see, normally you put a dorsal slab, okay. So the volar side, there is going to be only cotton and bandage roll. So this, even when there is some swelling, this is going to expand along with that, and it's not going to cause any great damage to the patient's forearm or forearm. Whereas when you apply a cast directly, that is when you circumferentially, you're going to apply a POP or a fiberglass, there is not going to be any space for the swelling to expand. So what it does is, it is going to compress the structure, compress the whatever structures are there within the compartment. So that's when the intracompartmental pressure rises, and the following, then the compartment syndrome sets in. Okay, so where did we start? Sorry. Okay. So coming to the causes, yeah. So fractures, and many times just native massages itself, massages, bandage. So all these can cause compartment syndrome. Then there are some chemicals which induce compartment syndrome. Okay, and so basically compartment syndrome is increase in compartmental pressure. So what it does, or what is the pathogenesis when you talk about it? So when there's increased compartment pressure, there should be some rent, there should be some opening for the pressure to come out. When there's no opening, so ultimately the fascia doesn't expand beyond a point. So the pressure, whatever pressure is mounting within the compartment, then it's transferred to the muscles, the vessels, and the nerves within the compartment. So what happens is, when the vessels are pressed, the blood supply to the distal part is stopped. When the nerve is pressed, again, it doesn't supply to the distal part. So ultimately, especially, it is the vascular problem because of the increased compartmental pressure. So when the vessel is pressed and when there is loss of blood supply to the distal part, the muscles start dying. Okay. So what happens is, when the muscles start dying, again, that is going to cause certain reactions, and it is going to increase the compartmental pressure even more. So it becomes like a cascade, wherein because of just the vascular, when there is a cessation of the vascular flow, that is going to cause the muscle damage, that is going to cause further swelling, that again in turn is going to cause more compartmental pressure, intracompartmental pressure. So this cascade, ultimately what happens, there is going to be death of the muscles and tendon. That is what you normally see, you call it as Volkmann's ischemia. Volkmann's ischemic contracture or Volkmann's ischemia is nothing but, Volkmann is the person who described it. So basically, when there is ischemia or when there is loss of blood supply to the particular part of the muscle, so that causes contracture. Okay, so and that is an irreparable one.
Okay, thank you, sir. So you also mentioned about septic arthritis in the beginning.
Okay, compartment syndrome. Shall I finish it off? What do you see? What do you have to see in compartment syndrome? How do you recognize compartment syndrome? Okay. See, compartment syndrome. So how do you recognize clinically? Now we know, okay, what compartment syndrome is. So how do we recognize compartment syndrome? See, compartment syndrome, patient with compartment syndrome, they're going to have extreme pain. Okay, first and foremost thing. And then second, when you look at the patient's limb, the part of the limb which they complain of pain, usually it will be like swollen out of proportion. There's going to be huge swelling, and it's going to be a tense swelling. Okay, and then when you try to elicit the patient's pulses, distal pulses, it's almost like it's going to be pulseless. Sometimes there might be pulse, but most of the times it is you're not going to have any pulse. Then already when I spoke to you about the CAT, that is the capillary refill time. When you try to check for the capillary refill time, it is going to be like prolonged. It's going to be like 8, 10 seconds, 15 seconds, depending on how bad it is. And then the most important finding that you need to look is something called a stretch pain. Stretch pain. So for example, when you want to check for the upper limb stretch pain, what you do is you try to extend the finger, any finger. Okay, you passively try to extend the finger. When for example, a patient with the supracondylar humerus fracture with compartment syndrome, or a forearm fracture with compartment syndrome, when you try to stretch it, they're going to have immense pain, wherein they'll be literally jumping out of the bed. So not even touching the affected part. Whereas you're just trying to stretch the finger in case of an upper limb compartment syndrome. The pain will be so immense that they'll be jumping. Okay, so stretch pain, see, because pulselessness, see, there are like 5 P's basically, which theoretically they say for compartment syndrome. Pulselessness, paresthesia, then pallor, that is the wherein pallor is nothing but the skin color is sort of, it is blanched and it is lightened in color. So pulselessness, paresthesia, then pallor, then this thing, stretch pain. Okay, whereas the stretch pain is the most sensitive indicator for compartment syndrome. Okay, so and how do you treat a patient with compartment syndrome? Here you have the answer for that in this picture. So they have done something called as fasciotomy. So when there is increased intracompartmental pressure, the pressure inside is not able to dissipate out. So what you do is you surgically go and open out the compartments. Okay, so forearm, you go open the compartment and you release the pressure. And this is a temporary measure wherein because it's not like you open and again you close it. So it's not going to serve the purpose. So you open, and most of the times you just put some sterile dressings, and then maybe after a week or 10 days, once the swelling subsides, then if possible you could do a secondary closure. If not, then you have to do a skin grafting and close this. So this is the treatment for compartment syndrome. And compartment syndrome, of course, theoretically when you read, they'll say you can measure the intracompartmental pressure using some manometers, Vicks manometer and all that. But to be honest, I have not seen one in my life till date. So it's all theoretical. It's more of a clinical finding, actually. Compartment syndrome, and you need to act immediately. I would say this is probably which one among these 3 emergencies, which one would you attend to first? I would say it is compartment syndrome. Because if you're going to miss it, the limb is gone.
Okay. So, and about the septic arthritis and how is it caused?
See, septic arthritis is nothing but when there is infection in a joint, you call arthro means, like all of us know, it is joint, and itis, that is a misnomer. Itis is in general, itis is called for inflammation, whereas here there is actually no inflammation, it is an infection. So arthritis here, it's a misnomer. So septic arthritis is nothing but it is infection in the joint. So that is septic arthritis. So what are the causes and whom do we normally see it? 90%, I would say septic, at least 80% septic arthritis are seen in children. Whereas in adults, you don't normally see septic arthritis, except in certain cases. It's pretty rare, I would say, in adults. So why septic arthritis and what are the causes for this? Probably, many times septic arthritis, just for example, a child would have had a trivial injury, just a slip and fall, and would have had some contusion in the knee joint, for example. What they immediately do, they start massaging, rubbing the joint vigorously, which is not to be done. Not only in children, even in adults, when you sustain an injury, never ever massage. That's the worst that you can do to yourself or to anyone. So whenever there's an injury, first and foremost thing, just ice the area. That's the safest and the best that you can do. So ice the area. So when there is vigorous rubbing, so what it does is when there is contusion, there is high possibility of the contusion getting infected. And in children, especially when the physis is opened up. So see, physis is nothing but the growth plate. So growth, I mean, like, see, in adults, usually the growth plates are seen at the ends of the bone normally. Do you have any picture for pediatric X-ray? Any pediatric X-ray pictures? Pavan?
Sir, no,
No, sir.
sir.
No.
Don't have. Okay, no problem. Okay, see, normally when you look at an X-ray of a child and when you look at the X-ray of an adult for any bone, I mean, like any joint, for example, you see two lines at the ends. No, these are all adult X-rays. Adult. Okay, fine, no problem, no problem. See, normally what you see is you'll see two lines or single line, like, there will be a gap, especially at the metaphysio-epiphyseal junction. Okay, so here the metaphysis is, see, this shaft is your diaphysis, and the part more towards the joint is a metaphysis, and the head here is almost like, the epiphysis. So there you see, normally you'll see two lines. So that is the physis or the growth plate. Okay, whereas in adults it is fused. Once the growth is over, it fuses or it closes. Basically, it's not fusing, basically closing. The physis closes. Whereas in children, the physis is open. So this physis sometimes acts as a barrier to prevent the infection into the joint. But when the damage is more, the mm, joint gets infected. So in children, the common causes are bacterial infections. So clinically, okay, how will you know, okay, a child or an adult has septic arthritis? First and foremost thing, it is like, when you look at their limb, again, like, for example, let us take the knee joint, for example. I guess Pavan had a good picture. Pavan, can you move forward? Septic arthritis. Okay, this, or maybe like, you had one more, like, where the picture was taken from the side. Or, okay, even that was okay, Pavan. Okay, see here you can see the difference between the right and left knee joints. See, right one, it is like, pretty normal, whereas the left one, here you can see there is market swelling. Okay, market swelling can be even without infection, but look at the redness around it. And see, usually it will be like, swollen, red, but redness is usually not seen in Indian, especially in South Indian. For our color, usually it is not seen. And it will be like, really, the warmth is what is going to, like, really differentiate it between a normal traumatic synovitis. See, even after an injury, for example, a child or an adult falls, there is going to be some collection in the joint. That can be blood, that can be just a synovial this thing fluid which can be collected inside. So how to differentiate between that and this? So just by a touch. So always touch using a dorsum. It will be like extremely hot or warm, you should say. So that whenever you touch and you see, okay, there is warmth, first and foremost thing that you need to consider is septic arthritis. See, not if the patient is febrile, but otherwise, first and foremost thing that you have to think of is septic arthritis. So how to confirm it? So septic arthritis, again, that is like, an acute thing. And one thing that you can do is, if it is like really swollen, you can put a needle, what you call as arthrocentesis. Arthrocentesis is putting a needle into the joint, whichever joint. So you put a needle, try to aspirate and see whether, like, you get any frank pus or the synovial fluid seems to be infected. So you can check for that. But sometimes you don't really get any aspirate in your arthrocentesis. So in such cases, what do you do or how do you proceed? See, I would say there's something called as negative arthrotomy. Arthrotomy is nothing but opening a joint. Opening a joint is called as an arthrotomy. So a negative arthrotomy is, okay, you open a joint thinking that there is going to be infection inside, but there is nothing in. But still, that is okay, acceptable. Because when there is septic arthritis, okay, whenever you suspect septic arthritis, especially, what happens is there's something called as the limb will be in pseudo paralysis. They call it as pseudo paralysis normally, because the pain is so severe that the child or adult, they're not going to be moving the limb at all. They won't allow you to touch the limb. It will be extremely painful. So, and here you can't really wait for your blood parameters and check for ESR, CRP, which you normally do in case of any infection. So you don't wait for all this. So whenever you suspect, you put in a needle, try to aspirate and see whether you get any aspirate. If you're getting, then well, go ahead and do a surgery. So the surgery or the treatment here is arthrotomy. That is, you open the joint, wash the joint thoroughly, keep some drain inside. So whatever is going to get collected, even post surgery, let it drain out for a few days. So let the drain be there for 3 to 7 days. Once it is completely dry, you can take out the drain. Okay, fine. Then but you still try to aspirate it. You're not getting it. Maybe you can just wait for some time and see whether the child is improving, child or adult is improving. But when there is no improvement, don't wait. Just go ahead and do the arthrotomy. Even if you're not going to get anything inside, it's okay. At least you have the peace of mind that, okay, there's no, I mean, it's not infected, and give a thorough wash. Once having opened it, give a thorough wash, keep it drain, come out. It's okay. Because if at all there is going to be septic arthritis, and if you missed it, the joint or the limb is gone. Because once there is infection in the joint, it is going to cause very rapid damage to the joint as such. So, and it leads to fibrosis. Okay, it leads to fibrosis. Then it can lead to normally what you call as fibrous ankylosis. Ankylosis is the joint being fused. Okay, there's no movement in the joint. That's called as ankylosis. So there are two types of ankylosis. One is bony and one is fibrous. So fibrous ankylosis is what is one of the main complications of septic arthritis. And then sometimes septic arthritis can lead to osteomyelitis, that is infection in the bone. So for example, when the knee joint is involved, when it crosses, sometimes it can cause infection of the femur or the tibia or fibula. Okay, so, and sometimes the infection can get into the bloodstream and cause septicemia and ultimate death. So septic arthritis, again, needs to be extremely, whenever you suspect septic arthritis, never delay, go ahead and do an arthrotomy. Maybe when you are really suspicious, when you're not really sure, then maybe you can wait for some time, but not really for a long time. Even then, try to get things ready for the surgery. Just wait for about an hour or two. And when the patient is not improving, just go ahead, do the arthrotomy. At least you're doing justice to the patient and you can be at peace.
Okay, thank you, sir. So now we'll be having a doubt session so that the participants can ask you all their doubts. So the first question is, if a joint is dislocated, and what is the timing that we have to go to the hospital? And if you don't go to the hospital at the right time, what are the complications? Let's see.
Okay. See, any trauma for that matter, ASAP, as soon as possible. As soon as possible, it's better, earlier the better. Why? Because, see, maybe after an hour or two from the injury, the muscle starts contracting. Okay, the muscle starts contracting. So what happens is, reducing by close means becomes a really tough task for the doctor, and then unnecessarily the patient has to undergo maybe see, then GA. See, most of the times we don't really give anesthesia and reduce, especially for shoulder or elbow dislocations. We just try to do it as such in the emergency room. So because when a patient needs to have a GA, then he has to be starving for at least 6 hours. Then he has to undergo a panel of tests, and then an unnecessary anesthesia that he has to undergo. So for that, earlier the better, because before the muscle starts stiffening, it's easy both for the patient as well as for the doctor. And see, in case of hip dislocations, for example, hip and shoulder sometimes, but hip, for example, because when there is hip dislocation, there is a high possibility of avascular necrosis to the femoral head. Okay, because hip is one of the joints which really doesn't forgive. So avascular necrosis for the femoral head, especially when the joint is dislocated and when it is lying there, in a dislocated position for about 4 to 6 hours or more, there is a high possibility of the patient developing avascular necrosis. So the earlier the better. Whereas for finger and other things, it is okay, but fingers, toes, all that's okay. But again, sometimes difficulty in reduction is always a problem. So hip never ever delay, shoulder never delay. And again, shoulder dislocation or any dislocation for that matter, I would say post reduction, once you reduce, strict immobilization is really mandatory for at least 3 to 6 weeks, depending on the joint, depending on the age of the patient, and depending on how bad the dislocation is. Or yeah, I would say anywhere between 3 or 4 to 6 weeks is mandatory, because shoulder joint, most of them especially people who go to bone setters, traditional bone setters, what they normally do is they reduce it. Even they do a good job. Even the bone setters, they do a good job. They reduce it and they put them on some sort of immobilizing, they put them on some strap. They don't put strapping, they put some sort of what do you say, bandages. Okay, but they don't really advise strict immobilization for a particular period of time. So what happens is, these people, see, once when the joint is dislocated, the pain is severe. It is they have enormous pain. But the moment you reduce the dislocation, the entire pain is like magic. The moment for example, the moment the humeral head pops inside the glenoid cavity, the pain is completely gone. They're absolutely fine. They don't have any pain at all. Okay. So what they do is, maybe they'll be a little scared for about couple of days. Then they just start using their limb as such. They don't follow the orders. Most of them, they don't follow the orders. Luckily, some they just escape without any issues. Whereas a lot of people, they start, they get dislocations, which is called as recurrent dislocation. See, the first dislocation or the first episode of dislocation, the force which is needed for the joint to dislocate is always enormous. Whereas in recurrent dislocation, especially in shoulder, you normally see in people between 18 to 30, 35. When you normally even try to throw a cricket ball, your joint dislocates. Okay, many times they get habituated so much that they just they just relocate the joint themselves. But what happens is, in the long run, when the joint keeps dislocating over and again over a period of time, it leads to there is a high possibility of the patient developing arthritis. So recurrent dislocation is one thing, especially which is commonly seen in shoulder. Not very common in other joints, but shoulder, yeah, it's very, very common. And otherwise, to repair that, once a patient has recurrent dislocation, then you need to operate them, and that needs a lot of it's an extensive surgery which is required, which can be just prevented by if the patient just follows the 4 to 6 weeks of immobilization. It's the chances of recurrent dislocation is very rare, I would say.
There are a lot of questions, sir, but due to the lack of time, the last question. So, what is the best management for cervical dislocation apart from the mere medical care? For example, C3 to C4 dislocation.
Okay. See, cervical dislocation, yeah. See, cervical dislocation, you need to evaluate it properly, because most of the times when there is dislocation of the, see, cervical dislocation is nothing but cervical spine dislocation. That's what they mean, C3, C4. So you need to have a proper CT evaluation to look for any associated injuries. And most of the times, if there is a C3, C4 dislocation as such, then patient is already quadriplegic. It is completely C3, C4, below C4, nothing is going to function. Okay, so normally what we do is, we put them on cervical tongs. We just reduce them and put on cervical tongs. See, all those Mira, all these braces, it's no more commonly used. Nowadays, it is more of, you, for the time being, you just put them on cervical tongs. You call it as Gardner well tongs. Okay, so you put 2 incisions and you put the pins here, and then there is a U-shaped frame, and from that, depending on the level of dislocation, okay, you have various measurements to add the weight for the traction. Okay, so you add that. And nowadays, if it is if it needs prolonged immobilization, nowadays the recommended treatment is go and surgically intervene and you can fuse it or you can fix it. There are various options to do that.
So the pediatric knee X-ray has been put in the screen you asked before.
Yeah, I mean, can you just, Pawan, can you just put one X-ray, a proper pediatric knee X-ray? I see. It doesn't need to be. Pawan, let it not be an arthritis X-ray because arthritis X-ray sometimes, I mean, like the architecture is gone. Just put a normal any pediatric. No, no, not septic arthritis. Just put X-ray of no Pawan pediatric knee X-ray. Just pediatric, yeah, pediatric knee joint X-ray. Okay, fine. That should be fine. Just open one X-ray. Just open one AP view. AP view should be fine. No, that's lateral view. AP view. See the one on the bottom, left bottom. Okay. See here, are you able to see like the distal femur just above the condyles? There is a line or there's a gap that you see. And again, the same thing again. I mean, like at the level of the tibial condyles also between the tibial metaphysis and the tibial condyles, you see a small gap. Hello, am I audible?
Yes, sir, you're audible.
See the gap that you see above the condyles and I mean like no above the femoral condyles and the gap that you see below the tibial condyles, that is the physis. So normally when you see an adult X-ray, you don't see all this. So that is why interpreting a pediatric X-ray, especially around the joint, many times it is very confusing because it is sometimes very difficult to differentiate a fracture from a physis. So the normally the dictum for to diagnose a pediatric case is whenever in confusion, always take the X-ray of the opposite limb, the uninjured limb, so that you have an idea about how much of physis is closed. So what you suspect as a fracture, whether it's a fracture or is it a physis.
Recent puberty, pregnancy, or lactation. Okay, that is simple enough. Nothing to take home from it. In the absorption. I have told that multiple levels in the entire life.
All the participants kindly mute your audio.
Malabsorption.
Yes, sir. So all the can you hear me?
Yeah, I'm able to hear you. Yeah,
Okay. So all the doubts of
I've
the
been cleared.
participants are cleared, I guess.
So I guess I made some justice to the orthopedic emergencies, or if you have any more doubts, please feel free to contact anytime, no
So
problem.
there are a lot of doubts in the chat box, but due to the lack of time, we couldn't ask you everything.
See, if you want to ask a few questions, please go ahead. If you have time, I'm okay with it.
Okay, sir. Um, so how to differentiate between this dislocation and fracture based on the time of the pain? If a child falls down and there is like how to immediately find what's the is it a dislocation or a fracture? Because the parents they'll be telling, okay, within 2 days it will be okay, so that don't go to the hospital and all.
No, no, no. See, uh, I don't think this question itself is right in the first place. See, how do you differentiate between a fracture and dislocation? See, without clinical examination and without an X-ray, sometimes it's very difficult to differentiate. So it is based on clinical examination, and ultimately it is the radiological investigation which is going to because many times what you think or clinically it is not really what you see in a radiology. Sometimes you get surprises when you take an X-ray or CT.
Like how to find whether a lower back pain is due to muscle or bone. The-
Okay. See, it is okay, fine. See, there are like, it's not exactly due to the bone. See, low back pain is not because of the bone. Low back pain is because of the disc, which is commonly which happens. Okay, disc problems are one of the, or I would say like, the most common reason for low back pain. Okay, and other than that, it is like, because of any muscle imbalance or muscle strain. Okay, so how do you differentiate? Again, that again, like, sometimes it is very confusing, especially in acute situations. It is very confusing. Whereas, okay, a patient has a chronic low backache, okay, maybe like, for weeks together or months together or years together. Yeah, there are like, various tests which needs to be done. The common one being straight leg raising test, which is like, you make the patient lie supine. Okay, patient lies supine, facing upwards. Yeah, that's okay, supine. You ask the patient to lift one leg, okay, one leg at a time without bending the knee. And then either patient can do it actively, or you can do an assisted SLR, that is an assisted straight leg, wherein you help the patient to raise the leg without bending the knee. Then you see like, how much, whether the patient has develops any back pain, or whether patient has develops any radicular pain, that is pain radiating from the back down to the leg of foot. Okay, depending on at what degree the patient gets this, then you can know whether is it because of the disc, or whether is it because of just a muscle pain. Many times just hamstring tightness, which probably like 70% of the population has hamstring tightness, because we don't like, normally exercise, or we don't focus so much on stretching especially. So many times hamstring tightness, or like, gluteal, I mean like piriformis or gluteus or quadratus lumborum, all these muscles tightness itself like, manifests as severe back pain. Okay, so yeah, when you do those tests, there are like, when especially the patient develops pain between 30 to 60 degrees, you normally like you think of some spinal pathology. When it is beyond 60 degrees, then you think of maybe like, some muscular pathology, maybe like hamstring tightness or piriformis tightness, or just a chronic muscle strain, lumbosacral strain.
So the next question is, if there is a shoulder dislocation to a patient, what is the probability to suffer from brachial plexus injury?
Brachial plexus injury. Brachial plexus, I don't think. Shoulder dislocation and brachial plexus injury, I don't think it happens. See, brachial plexus injury, yeah. See, common causes for brachial plexus injury are, I would say, like, massive, like, very, very high velocity road traffic accidents, yeah, can cause brachial plexus injury. Or one of the common causes for brachial plexus injury is especially someone like, they fall from like 1 or 2 floors height, 3 floors height. They just try to grip onto something, whatever is there on the way, like, they just try to hold on. So what happens is they'll be able to hold it somehow. But when there is a sudden stretch of the plexus, so that causes like, many times it causes root avulsion and other like, major injuries, brachial plexus injuries. So, but normal shoulder dislocation with brachial plexus injury, I don't think. See, axillary nerve injury can happen. Musculocutaneous nerve injury, yeah, can happen at times. But brachial plexus, uh, see, at least I have not heard about it. I'm sorry. Maybe I can check and revert back to you. I'm not sure. See, because yeah, fall from height associated with brachial plexus injury, yeah, it happens because of sudden clenching of some object, because of the force, like, because when there's a sudden you fall with the force, especially with the body weight. Whereas when you try to hold on to something, the plexus stretches and sometimes it avulses, or it rips apart. So yeah, that causes. But normal shoulder dislocation, I don't think it causes it.
Okay, sir. So could you please tell us about an input about the bilateral and unilateral TMJ injuries and locked jaw disorders?
Locked jaw disorders. See, I don't think I'm really the right person to talk about it. Probably a dentist, like, especially an OMFS person should be the right person to talk about it. See, yeah, TMJ dislocations, yeah, we encounter, and sometimes when the dentist is not available, we try to reduce the TMJ dislocations. But other than that, my knowledge about TMJ joint per se is very limited. Let me be honest, because that is beyond the scope of orthopedics. one thing whether you think about TMJ joint is, see, one thing is when someone in the age of about 15 and above, okay, when they complain of chronic TMJ pain, it can be the first sign of the patient developing rheumatoid arthritis. Okay, so whenever someone complains of chronic TMJ pain and when all the other causes are ruled out by a dentist, then it is better to get the patient evaluated for rheumatoid arthritis. Okay, that is one of the first signs of, I mean, first symptom of rheumatoid arthritis. Not for everyone, but for many.
Okay,
Yeah.
so okay.
See, lockjaw, yeah,
Um,
I have reduced probably like maybe 8 to 10 cases of lockjaw. I've reduced the TMJ dislocations, but that was because there was no dentist available, and I was actually taught by a professor on how to reduce it. But even I don't think most of them know how to reduce a lockjaw. I mean, most of the orthopedicians or doctors in general, medicals, they don't know because it is, or maybe ENT people, they might be knowing about it, but not. It's beyond the scope of ortho.
okay, so in all our homes, we are having elder people, and most of them we have seen every elder people will be having some sort of knee pain and all. It's very common. So, what do you
So
think is the cause of that?
it is arthritis. It is arthritis, osteoarthritis. So osteoarthritis is definitely the leading cause of knee pain in anyone above 45 or 50, I would say.
So, so how do you how can we diagnose it in? Can we diagnose it in home? Like
You
it's
can,
osteo.
you can. See, yeah, arthritis is basically, yeah, okay, see, again, osteoarthritis is nothing but degenerative arthritis. Okay, it is because of the aging. Okay, so how do you diagnose it? Okay, first and foremost, right, from coming from the demographics of the patient. Okay, patient is above 50, 45, 50, complaints of knee pain, especially the pain will be okay, in little advanced, moderate to advanced stages, they'll be having pain even at rest or while walking on a flat surface, they might be having pain. Otherwise, initially they'll be having pain on climbing stairs, on cross leg sitting, squatting, and especially more than climbing stairs, actually getting downstairs will be a difficult task for them. So that is that will be their complaints. Then on examination, when you look at the knees, sometimes it might be swollen because of synovitis. Okay, so and then you try to palpate the joint line. So how do you palpate the joint line? Okay, see, you just try to make them lie down, okay, and just flex the knee to about 30 to 40 degrees. And when you try to palpate the tibial tuberosity, palpate the tibial tuberosity with your thumb and keep the thumb and index finger on either sides of the tibial tuberosity and just try to go up the go upwards and go upwards and outwards, just because your condyle flares out. Okay, so when you go, you feel a depression between your femur and tibia. So the depression that you feel is the joint line. So joint line is, or the space that you normally see in an X-ray in the knee joint. It is not actually a space. It is the space which is actually occupied by your articular cartilage, your meniscus. Okay, so that is what you, since they are soft tissues and you don't normally visualize soft tissues in an X-ray, so you just see it as a space. Okay, so you try to palpate for any joint line tenderness, and then usually they'll be having pain when they try to flex and extend the knee. So this is how you normally diagnose. And when you want to confirm, take an X-ray. And just remember one thing: when you want to actually see for an arthritis, when you take an X-ray, try to always take a, see, for knee joint, you take an AP and lateral views. Okay, AP view and lateral views. So when you take an AP view, unlike for other conditions, for an arthritis, try to take a standing AP. That is, you make the patient weight bear and take an X-ray, because in the early arthritis, you won't see the narrowing of the joint space normally. Whereas on a weight bearing X-ray, that really pops out. So you don't tend to miss it out. And how do you prevent it, or what do you advise them not to do it? Okay, again, like, whatever is causing the pain, again, like, ask them not to climb stairs, ask them not to sit down on the floor, ask them not to cross like, ask them to avoid cross leg sitting, ask them not to squat, ask them not to use Indian toilets, and ask them not to see walking on a flat surface is absolutely fine. That is, like, in fact, it is recommended, but ask them not to climb uphill or downhill. So all these things are to be avoided. And then what else can you do? Yeah, see, maybe you can give them some painkillers. You can ask them to use some hot packs or ice packs to take care of the pain. And then you have, again, like, a lot of supplements are available. Initially, you had some see, basically, supplements are nothing but chondroprotectors. So, whatever chemicals which, like, protects your cartilage, at least existing cartilage, there's nothing proven till date which helps in regenerating the cartilage. So, whatever cartilage is left, at least you try to protect it and try to prolong the life of your native knee joint. Okay, that is possible. That is, like, latest ones are collagens basically. Then you have other options like, steroid injections, intraarticular. That is, you give intraarticular injections of steroid. Then you have hyaluronic acid. Then you have PRP, that is platelet-rich plasma. Platelet-rich plasma is nothing but patient's own blood is withdrawn, and then it is centrifuged, and just the plasma alone is taken. The platelet-rich plasma alone, that layer is taken and it is injected. And cheapest of that is steroid, and the costliest of that is PRP. Even though it is your own blood, to prepare and to give it, they charge anywhere between 25 to 30,000 rupees. So these are the options available. And then in a moderate stage where they have, like, see, because again, meniscal tears and other things can, yeah, see, a patient elderly. So this is just a practical tip. An elderly person, probably, like, beyond like 55, 60 or above, probably with an arthritis in the knee, they complain of sudden pain without any much injury. You just think of two things, which is, like, practically you just get two things in such instances. One is, you I don't know whether you know what is an osteophyte. Osteophyte is, like, when you look at an X-ray of a patient with arthritis, there are, like, you see bony spurs at the ends of the bone, or, like, on the peripheries of the bone, you have some bony spurs. So that is called as an osteophyte. Okay, so that osteophyte can fracture. That is one thing. And second thing is the meniscus which is there in the joint. There will be a degenerative meniscus tear. So that is also one. So these two are the common things which causes acute pain in case of a arthritic knee without any major injury. And then the last option again is, like, surgery. Surgery, again, you have a lot of options: arthroscopic debridement, then partial knee replacement, total knee replacement.
Okay, so the last question. So what do you think is the choice of treatment for cervical spondylitis?
Cervical spondylosis. Okay, fine. See, for cervical spondylosis, yeah. See, cervical spondylosis, again, nothing but it is, again, like, a degeneration of the cervical spine. What you call it as an osteoarthritis in the knee or hip is the same, the cervical spine. It is because of aging. Okay. So what you can do to prevent it, okay, maybe, like, avoid mobile for a long time in the younger age. Okay, that itself is one of the main reasons for early cervical spondylosis. And yeah, once you get the cervical, okay, a patient, already a person has cervical spondylosis. So what is to be done when they have severe pain? Okay, you can, like, ask them to take some medications. Then there are, like, a lot of physiotherapy modalities which are available. Traction. Then you can give them interferential therapy, which is commonly called as IFT, and all that. Then above all this, the most important thing is exercises for the neck. What you normally call it as isometric neck strengthening exercises. So these exercises, basically, you try to strengthen the muscles around the neck. Okay, the neck muscles you try to strengthen so that the patient maintains the posture and you prevent further insult to the already degenerated cervical spine. And again, you ask them not to, like, bend a lot. Ask them not to lift heavy weights, especially people who try to, like, the village people who try to lift, who carry load on their head. You ask them not to do all this. So that's it. Cervical spondylosis is one of the conditions where the patient is not really satisfied with your treatment.
Okay, sir. So this is the end of the doubt session. So this was a really informative session, and thank you, sir, for accepting our request and coming and solving all our doubts. And I hope all the participants have gained a lot of information from this webinar. So,
Thank you so much for giving me this opportunity, and I hope I did some justice at least.
yeah,
Yeah,
sure,
thank you.
sir.
Thank you so much, sir. It's like we are so glad to work with you. Yeah, sir. Thank you. Thank you so much.
Thank you, Pawan. Thank you. Bye. It was my pleasure.
Thank you, sir. Thank you. Guys, kindly fill the feedback form which is posted on the chat box. So if you guys fill the feedback form, you will receive your valid e-certificate within 7 days of duration. If not, please contact the organizer, that is the professional help. We are available on Instagram, Facebook, and also you can personally text us to our numbers. So guys, kindly fill the feedback form. We'll wait for 2 more minutes. Thank you, guys.
Thank you.
Thank you all. So, hereby we'll be ending our live session. Thank you all for joining. Good night. Take care.